the hormone disorder affecting 1 in 10 women, and why it goes undetected for years. Here is a number from the World Health Organization. 1 in 10, that is the proportion of women of reproductive age currently affected by Polycystic Ovarian Syndrome, one of the most common hormonal disorders on the planet. And here is the number that should alarm every one of us, even more. 70%. That is how many of those women, according to the WHO, do not yet know they have it. We are not talking about a rare condition. We are talking about a global health crisis, affecting hundreds of millions of women, in which the majority are going years without an accurate diagnosis, without answers, and without proper care. In this video, we are going to change that. We will cover exactly what PCOS is, how it works, who is at risk, every major symptom, the serious long-term complications the research has identified, and what the current evidence says about managing it effectively, the scale of the problem. To understand why PCOS being undetected matters so much, you first need to understand how common and how serious it actually is. The WHO designates PCOS as a significant global public health problem, the most common hormonal disorder in women of reproductive age, and the leading cause of anovulatory infertility worldwide. A 2024 comprehensive meta-analysis by Solari and colleagues, published in Archives of Gynecology and Obstetrics, analyzed 35 studies covering over 12.3 million subjects. They're finding a global PCOS prevalence of 9.2%, rising to 11.5% when the broader Rotterdam diagnostic criteria are applied. The Global Burden of Disease Study, 2021, one of the most comprehensive epidemiological analyses ever conducted, found that PCOS incidence rose by 56% between 1990 and 2021, with new cases climbing from 1.43 million per year to 2.23 million. A 2025 analysis, published in Reproductive Health by Springer Nature, found that by 2021, the global age-standardized prevalence of PCOS had increased by 28% since 1990, and the trajectory is continuing upward. The same GBD-based research projects that PCOS prevalence, incidence, and disability-adjusted life years will continue rising through 2036, with forecast increases in incidence rates of over 8%. This is not a stable condition. It is an expanding global epidemic, and most of the women inside those numbers have never been told they are in them. This is the core of our title, and the research answers it directly. In 2017, Gibson-Helm and colleagues published a landmark study in the Journal of Clinical Endocrinology and Metabolism, surveying 1,385 women with confirmed PCOS across North America and Europe. The results were striking. 1/3 of women, 33.6%, reported waiting more than 2 years before receiving a diagnosis. Nearly half, to 47.1%, had to see 3 or more healthcare professionals before being diagnosed. Only 35.2% were satisfied with their diagnosis experience. Only 15.6% were satisfied with the information they received at diagnosis. A 2021 cohort study, published in Human Reproduction, Oxford Academic, found that in a community-based sample of 974 women, half of those who met the Rotterdam criteria for PCOS had never received a clinical diagnosis. Why does this happen? The reasons are systemic. PCOS, symptoms, irregular periods, acne, fatigue, weight changes, are dismissed individually as normal variation. In adolescence, symptoms overlap with puberty and are routinely overlooked. The condition's name is a misnomer, creating confusion among patients and clinicians alike. And critically, PCOS is severely underfunded. In 2024, NBC News reported that among 315 medical conditions receiving federal research support from the National Institutes of Health, PCOS ranked near the bottom, with only $10 million allocated for research in 2024. Until 2022, PCOS was not even listed as a line item in NIH funding records. The 2023 International Evidence-Based PCOS Guideline, The most authoritative standard of care in the field explicitly acknowledged this in its opening statement. Diagnosis is still delayed. The needs of those with PCOS are not being adequately met. Evidence quality was low, and evidence practice gaps persist. The system has known this for years. The problem has persisted. Anyway. Segment 3. What is Polycystic Ovarian Syndrome is a chronic, multifactorial endocrine and metabolic disorder. It manifests clinically through 3 core features, and understanding them is essential to recognizing it. To diagnose PCOS, clinicians use the Rotterdam criteria, which requires at least 2 of the following 3. 1. Ovulatory dysfunction, irregular, infrequent, or absent. Ovulation reflected in menstrual cycles longer than 35 days. Fewer than 8 periods per year, or absent menstruation. 2. Clinical or biochemical hyperandrogenism, elevated androgen levels on blood testing, or visible signs such as hirsutism, acne, or scalp, hair thinning. 3. Polycystic ovarian morphology, either on ultrasound or as updated in the 2023 International PCOS Guideline, confirmed by elevated anti-Müllerian hormone (AMH) levels, as an alternative to ultrasound in adults. The word polycystic is technically a misnomer. What appear on ultrasound are not true cysts, but follicles, small, fluid-filled sacs, each containing an immature egg that failed to develop and release due to hormonal disruption. For key mechanisms drive this disruption. Androgen excess. At least 60% of women with PCOS show evidence of hyperandrogenism, elevated testosterone, or DHEAS, or androgen-driven symptoms at the skin and hair follicle level. Insulin resistance. Approximately 70% of women with PCOS have some degree of insulin resistance, including women who are not overweight. Excess insulin directly stimulates the ovaries to overproduce androgens, creating a self-reinforcing cycle. LH-FSH imbalance. The ratio of luteinizing hormone to follicle-stimulating hormone is often disproportionately elevated in PCOS, impairing normal follicle maturation and blocking ovulation. Chronic inflammation. Research consistently identifies low-grade systemic inflammation in women with PCOS, which independently stimulates androgen production and worsens insulin resistance. Symptoms. PCOS symptoms vary widely between individuals and change over time, which is one of the primary drivers of diagnostic delay. Menstrual and ovulatory. Cycles longer than 35 days or fewer than 8 per year. Amenorrhea, complete absence of menstruation, heavy or prolonged bleeding when periods occur. Signs of androgen excess. Hirsutism course. Dark hair on the face, chin, chest, abdomen, or back. Persistent acne, particularly along the jawline, often resistant to standard skincare. Androgenic alopecia, diffuse thinning at the crown or temples. Metabolic weight gain, concentrated in the abdomen. Difficulty losing weight despite dietary effort. Acanthosis nigricans, dark thickened skin patches at the neck, underarms, or groin, a clinical marker of insulin resistance. Reproductive. PCOS is the leading cause of anovulatory infertility worldwide. The 2021 cohort study in human reproduction found that women with a prior PCOS diagnosis were 4 times more likely to have reported fertility difficulties than those without PCOS. Mental health. Depression and anxiety are formally recognized features of PCOS, not secondary consequences. The 2021 human reproduction cohort study found that clinical depression was 50% more prevalent in women with PCOS, whether diagnosed or undiagnosed, compared to women without the condition. Uranos Health 2024 reported that approximately 40% of women with PCOS experience depression or anxiety, with links to fatigue, sleep disturbance, body image, and the compounding effect of years without a diagnosis. Segment 5. Risk factors. Genetics. PCOS has a strong hereditary component. First-degree relatives, mothers, sisters, daughters, carries significantly elevated risk. A 2024 study at MDP I found that participants with a family history of PCOS had a significantly elevated relative risk of developing the condition. Genetic research has identified susceptibilities across pathways involving insulin signaling, androgen metabolism, and gonadotropin regulation, obesity and metabolic health. Excess adiposity, particularly visceral fat, amplifies insulin resistance and worsens hormonal dysregulation. The same 2024 MDPI study found obesity was a strong predictor of PCOS symptoms across both study populations. However, the condition affects women of all body sizes. Insulin resistance in PCOS is not restricted to women with obesity. Age of onset. The 2025 GBD analysis, published in Reproductive Health, found that PCOS prevalence peaks globally in women aged 15 to 19. A separate PMC analysis of adolescents found that PCOS affects between 6 and 18% of females aged 10 to 24, and that symptoms during this period are routinely misattributed to puberty. Ethnicity. The WHO explicitly states that the prevalence of PCOS may be higher among women in some racial or ethnic groups, with higher genetic propensity for metabolic complications noted in certain populations. REF1. The WHO also acknowledges that structural racism and social determinants of health shape the extent to which different groups of women seek and receive quality care, a factor that compounds the diagnostic gap. The Solari 2024 meta-analysis found particularly high prevalence on the African continent, reinforcing the need for population-specific screening. Environmental factors. Emerging research identifies endocrine-disrupting chemicals, including bisphenol A (BPA), as contributing factors. Studies have found elevated serum BPA levels in hyperandrogenic women with PCOS compared to controls. Diet quality. Physical inactivity, gut dysbiosis, and urbanization are also implicated in the 56% rise in global incidence over 3 decades. This segment is where the going undetected for years part of our title becomes clinically critical. PCOS is a chronic, lifelong condition. The complications of unmanaged PCOS span multiple organ systems, and they are well documented in the literature. Women with PCOS are approximately 2.5 times more likely to develop type 2 diabetes than women without PCOS. The WHO lists insulin resistance, type 2 diabetes, and obesity among PCOS's most significant long-term risks. Research, cited in a 2025 Frontiers in Public Health analysis, confirms that women with hyperandrogenic PCOS carry an even higher metabolic burden, with elevated risk of dyslipidemia and impaired glucose tolerance from an early age. A 2023 meta-analysis published in the Journal of the American Heart Association, covering data from over 1 million women, including 369,317 with PCOS, found significant associations between PCOS and composite cardiovascular disease, ischemic heart disease, myocardial infarction, and stroke. The 2023 International PCOS Guideline now formally recommends universal cardiovascular risk assessment for all women with PCOS. Without regular ovulation, the uterine lining accumulates without shedding, a process called endometrial hyperplasia. The WHO identifies this as a direct risk pathway to endometrial cancer in women with PCOS. A 2024 meta-analysis in PubMed quantified a nearly 3-fold increased relative risk of endometrial cancer in women with PCOS. The 2023 International Evidence-Based PCOS Guideline, endorsed by 39 professional societies and consumer organizations across 71 countries, incorporating 254 recommendations, provides the current global standard of care. Management is individualized, based on symptoms and reproductive goals. A lifestyle intervention. The 2023 guideline designates a supported, healthy lifestyle as the cornerstone of PCOS management throughout the lifespan. For women who are overweight, Even a 5 to 10% reduction in body weight produces clinically meaningful improvements in insulin sensitivity, androgen levels, menstrual regularity, and ovulation. Evidence-based lifestyle principles. Reduce refined carbohydrates and added sugars, the primary driver of insulin demand in PCOS. Anti-inflammatory dietary patterns. Mediterranean-style eating has shown measurable improvements in PCOS metabolic markers. Exercise. Both aerobic and resistance training improve insulin sensitivity independently of weight loss, the guideline recommends. 150 minutes of moderate intensity activity weekly, with resistance training 2 to 3 times per week. Sleep quality and stress reduction, formally recognized as metabolic therapy targets in the 2023 guideline. The guideline explicitly addresses weight stigma. Clinicians are instructed to minimize bias, seek consent before discussing weight, and provide evidence-based support rather than prescriptive advice. Topical treatments. Eflornithine cream for facial hirsutism, laser hair removal, and electrolysis are recognized adjunct options. Fertility management, first-line. Letrozole, an aromatase inhibitor, is the preferred first-line treatment for ovulation induction in PCOS, demonstrating higher live birth rates and lower multiple pregnancy rates than clomiphene citrate. Second-line, clomiphene, plus or minus metformin, gonadotropins, for women who do not respond to letrozole clomiphene citrate, often combined with metformin and injectable gonadotropins, with careful monitoring, are available. Third-line, IVF, IVM, in vitro fertilization, potentially with in vitro maturation, IVM, particularly suited to women with PCOS, is available when other approaches are unsuccessful. Mental health. The 2023 guideline mandates routine screening for depression, anxiety, and disordered eating at diagnosis, with repeat screening based on clinical events including the perinatal period. Evidence-based treatment. CBT, pharmacotherapy, and multidisciplinary support should be initiated when conditions are identified. Long-term monitoring. All women with PCOS require ongoing surveillance for fasting glucose and HbA1c diabetes, lipid panel, and blood pressure. Cardiovascular, endometrial health, particularly with prolonged sleep apnea, symptoms newly formalized in 2023 guidelines. The WHO affirms that PCOS is a chronic metabolic condition that persists. Beyond the reproductive years, metabolic and cardiovascular risks continue into the postmenopausal period and require lifelong monitoring. CLOSC Injitha, who confirmed it. 1 in 10 women has PCOS. The research confirmed it. Up to 70% do not know. The clinical literature confirmed it. 1/3 wait more than 2 years for a diagnosis, seeing multiple clinicians, often walking away with no information, and the complication data confirmed it. This delay has real, measurable, life-altering consequences for metabolic health, cardiovascular health, reproductive outcomes, and mental well-being. But what is also confirmed by the research is this: PCOS is manageable with evidence-based lifestyle intervention, appropriate medication, proper monitoring, and informed, patient-centered care. The trajectory of this condition can be substantially improved. The 2023 International Guideline exists. The evidence exists. What has been missing is the conversation. This video is part of changing that. If this gave you clarity, share it with a friend, a sister, a colleague who has been searching for answers. Subscribe for more evidence-based health content. Leave your questions in the comments.